Welcome in once again to another Evergreen Talks with Evergreen Family Medicine. The second Thursday of every month at 4 o'clock, it's time for Evergreen Talks, our monthly Facebook Live event where physicians and providers and specialists from Evergreen Family Medicine present topics that matter to you. And you can see previous editions of the Evergreen Family Medicine Evergreen Talks online at evergreenfamilymedicine.com and also on the very same social media channels that you're on right now, Facebook and YouTube as well. We'd like you to use the live chat as your opportunity to ask questions as we go through the presentation today. And we will get to those questions after the presentation. And today we are joined by Michael Graham, who is a PA at Evergreen Family Medicine. Good to see you. I'll turn it over to you, and we look forward to what you have to tell us about today.
Yeah, definitely. So today I'm going to be talking about dementia. And I'm going to try to keep it brief. I'm going to try to keep it under 20 minutes. And this is a big topic. There's lots of things to talk about. But in less than 20 minutes, obviously, we're not going to get to everything. But I'm going to try to give you the 20,000 foot view on dementia and answer some of the common questions and kind of go from there. It's a really important topic that you'll see. So let's go ahead and go to the next slide. So dementia, we've all heard that word, and a lot of times we use dementia interchangeably with like Alzheimer's and stuff like that. Well, there's actually a few different types of dementia. Alzheimer's, which is the one that is most common, about 60 to 80% of cases, is one type of dementia. There's two different kinds of Alzheimer's, early and late. And you can see there's some numbers on there, 5 to 10%. The cases of Alzheimer's are early dementia, but the overwhelming majority of cases of Alzheimer's are late dementia, which is the most common thing that we generally see out in the public or experience in our own lives. There's Lewy body dementia, vascular dementia, and frontotemporal dementia. Those are three other kinds. In 20 minutes, we're going to talk about Alzheimer's because it's the most common. So let's go ahead and go to the next slide. So Alzheimer's, here's our goals for today. What is it? Who gets it? How can I prevent it? And how can I treat it? You see these flowers on the left. These are actually from our garden. And I was looking for pictures to put into my slide, and I found these. And my wife will be really happy that I get to show off some of her flowers in my talk. So it does not have anything to do with Alzheimer's, just a pretty flower. So let's go to the next slide. So what is Alzheimer's? Well, it's a neurodegenerative disease leading to progressive and gradual loss of memory, function, and ability to learn new information. The cause is still debatable, but there's a lot of hypotheses out there. So what does it look like on slides? Well, after people pass away, you can view brain slides via microscope and do different stains. And what you'll see are these hallmark changes of diffuse and neuritic plaques marked by extracellular amyloid beta deposition and neurofibrillary tangles. So I put that in English here just for most of us to understand. So Alzheimer's, the thought is that there's these proteins in your brain, specifically on the neurons of a cell, that become misshapen over time. When those proteins become misshapen, they get kind of sticky and they clump up together and they cause inflammation. And they kind of break up some of the signaling of the brain. They create damage to the neurons. So that's one of the plaques that form. And then there's another one inside of the neuron, so inside of the cells, where these other proteins also have a similar thing. They get misshapen, they get sticky, they actually destroy kind of this highway signaling that our neurons use to send information up and down the cell. When that gets destroyed, it makes it difficult for neurons to synapse or send messages to each other. And so you'll see a lot of cellular death, which leads to brain atrophy, which leads to a lot of the problems that we talked about with memory and function and stuff like that. The plaques, so those amyloid plaques that I was talking about, have actually been the target of a lot of new therapies, and it's actually been the target of research for a number of years. Well, none of those have been effective. And interestingly enough, the burden of the plaques in your brain actually doesn't correlate to illness severity necessarily. So let's go to the next slide. We'll talk about a little bit more of that. So who gets Alzheimer's? Well, 47 million people have it right now in the entire world. The incidence of dementia, so the chances of somebody getting it, essentially doubles every 10 years after age 60. 1 in 6 people over the age of 80 have dementia. So you can see just from those numbers, like a lot of people get dementia, especially in some of the more developed countries where people tend to live longer. You can see the longer somebody lives, the higher chance they have of having dementia. And I'm using dementia interchangeably with Alzheimer's here, just so you guys know. Does family history increase risk? Well, yeah, for some cases, but the majority cases, it probably raises some of your risk, but not, we don't think in a super significant way. Now that's being researched currently, and they're trying to identify different genes that are associated with that, and they have identified different genes. However, we haven't quite figured out what the ultimate risk is for having family members that have Alzheimer's. There is this thing called cognitive reserve, which basically the higher your cognitive function is to start with, the less chance you have of getting Alzheimer's. But you're actually still losing cognitive function kind of at the same rate as other people. However, if you start off really high, it's difficult to lose at such a rate where you meet criteria for Alzheimer's. And I have a slide to kind of show that later. One of the interesting thing about who gets Alzheimer's is that actually the problem starts about 30 to 50 years before your symptoms. So you can see if someone develops dementia at age 80, there's a chance that they could have had developing changes in the brain at age 30. And so that's something to certainly think about. It actually, when you think about it that way, this talk applies to everybody. So some of the modifiable risk factors, so what makes you more likely to get it or less likely, diabetes, having high blood pressure, smoking, alcohol intake above excessive amounts, a sedentary lifestyle, air pollution, poor sleep, and head trauma are just some of them, to name a few. Now, modifiable risk factors are things that you and I have control over being able to change or modify. A risk factor for Alzheimer's is age. Well, we can't change that. So that it would not be considered a modifiable risk factor. However, that is one of the biggest risk factors. Let's go to the next slide. So I talked about cognitive reserve. I drew this out. It actually took me way longer than it should have. I made this graph. You can see on the bottom, on the x-axis, you have time. On the y-axis, you have initial level of cognition, so cognitive ability. You can see somebody who starts off high, which is the blue one, they will lose cognitive ability throughout time. However, at that rate, they never actually cross that line that gets into dementia. Whereas you have somebody who has a lower cognitive ability to start with, they cross that line into dementia much earlier. Both of those lines are losing cognitive ability at the same rate. However, one starts lower and therefore has a higher chance of getting dementia. Next slide. So how can I treat Alzheimer's? Well, unfortunately, there's about a 99.6 fail rate of Alzheimer's drugs in testing. Not very good. That's despite millions and millions and probably billions of dollars of research. This is obviously a disease that affects people significantly and has a huge disease burden. Not only does it affect a lot of people, but you think about the people that are involved in somebody's care who have Alzheimer's. You think of the amount of money that goes into some of our retirement facilities. You think of some of the lost time and wages of family members taking care of people with Alzheimer's, and there's a huge burden, both socially, mentally, with as far as money goes. It's a big one. So we need to find something that works, but we just haven't. So what is out there? Well, we have these neuromodulators. We have these things called cholinesterase inhibitors. That would be a medicine called like donepezil. We have NMDA receptor antagonists, which that would be a medicine called like memantine. And then we have a new immunologic. I'm not even going to try to pronounce that, but you can see aducanumab, I think is how you pronounce it. But yeah. So, and that's a new medicine actually. And we'll talk about that a little bit on the next slide. So what are future target therapies? Well, so far we look back at the hypothesis of all these plaques and stuff forming, and people have been trying to figure out how do we reduce these plaques? And actually one of them has reduced the plaque, but the medicine didn't work that well. And so some of the people are starting to ask kind of like, well, maybe instead of asking how do we get rid of these plaques, maybe we need to look further and say like, well, why are we getting them? This would be, you could liken this to if you go way back in time and somebody who had diabetes had tingling in their feet. And they spent all this time and research looking at like tingling and nerves and stuff like that. And they are trying to treat the nerve pain without ever realizing that it was a problem with sugar and insulin resistance. They're starting to think that maybe we've kind of thought the wrong thing on how to treat Alzheimer's, but we'll talk about that. So next slide. So what is the treatment efficacy? So how well does this stuff work that's already out there? And what's our goal of treatment? Well, when I talk with patients about medicines and options, we always set kind of a goal, or at least set an expectation. So our goal with the treatment of Alzheimer's is to improve function. It's to try to keep people out of try to keep them out of care facilities. It's trying to lessen the burden of care required by the family. Those are some of our goals. The medicines we have might slow the progression, maybe, but their actual effect is minimal. I was at a conference this last year and they were talking about this, and one of the neurologists said, actually, our goal is basically 1 year of help. We want to try to stabilize memory loss for hopefully at least 1 year. After that, everything else is bonus. But really, you're just hoping for a year. So those cholinesterase inhibitors I talked about, those are indicated for people with mild to moderate dementia. They have a mild to moderate benefit. You look at some of the studies and it is negligible. It really is. Some people respond well. Some people don't. A lot of people have side effects, but it's what we have. The NMDA receptor antagonist, that would be like memantine. That's indicated for moderate to severe dementia. That also has a mild to moderate benefit. Very similar to the cholinesterase inhibitors. When used in combination, they seem to work a little bit better. But again, people have a lot of side effects from these medicines. They don't work that great. Their benefit is minimal, which is unfortunate. The immunologic, that was the new medicine that I was talking about. That was approved by the FDA, and there is a ton of controversy around that medicine. A lot of the studies showed absolutely no benefit and actually a huge risk of side effects. And they were side effects including brain swelling and bleeding and stuff like that, which is obviously a significant and terrible side effect. They're super expensive. People that usually we saw that people with dementia tend to be older. A lot of them tend to be on Medicare. Who is Medicare going to pay for those medicines? Probably not. We don't know who's going to pay for it right now. Are private insurers going to pay for it? I haven't seen anybody pay for it yet. There's lots of side effects. And again, this medicine was really controversial. If you look into some of it, most of the approval committee actually said, do not approve this medicine. However, it was approved anyways. I haven't seen it used yet. So Unfortunately, this slide is a negative slide. There's really not a whole lot out there. There's really not much that we can do. We have some of our tools, but they're just not great tools. We really, this is one of the areas of medicine where we really, really, really need something else, and we just have not got it yet. Next slide. So once you have it, difficult to treat. Maybe for us, as we wait for a medicine to come out, our focus needs to be on prevention. Thankfully, 1/3 or more cases of Alzheimer's are thought to be preventable. It's a big percentage of people. We talked about modifiable risk factors, so things that you can do or I can do to lessen my chances of getting Alzheimer's. Some of those modifiable risk factors would be having diabetes or high blood sugar, high blood pressure, smoking, alcohol intake above recommended amounts, a sedentary lifestyle, pollution, poor sleep, head trauma. So what should we do? Well, let's eat a healthy diet. I would look back onto some of the talks on here. Dr. Racine gave a talk. Dr. Dower gave a talk on diet and exercise. Those are great resources for you. They're chock full of really good information. That would probably be one of the best things you could do to lessen the chances of you getting Alzheimer's. Number 2, you should never start or you should stop smoking if you do. It's pretty self-explanatory. It's difficult to do, however, necessary. I would keep alcohol intake to less than 1 to 2 drinks on average per day, less than 14 per week. And those are standard alcoholic drinks, not the ones that a giant can, like a 32-ounce beer would count as 4 drinks of alcohol. So that would not count as one. Number 4, which is super important, get at least 150 minutes of moderate to vigorous physical activity each week. That is a minimum recommendation. If you refer back to other talks, we talked about moderate to vigorous. That's basically something that gets your heart rate up. So mowing the grass, going for a hike, riding a bicycle, those are moderate to vigorous. Going on a leisurely walk is great. However, does not meet moderate to vigorous intensity. Something you should still do, but does not meet the intensity. Number 5, which is a hard one, especially for Americans, get 7 to 9 hours of quality sleep per night. Americans sleep poor. A lot of people do. A lot of people don't get 7 to 9 hours of sleep every night. I see that a lot in clinic. You need to make sure you're getting at least 7 to 9 hours, and you need to make sure that those hours are quality. I refer people a lot to reading a book called Why We Sleep by Matthew Walker. It's a great resource on kind of sleep health. Number 6, and the last one, wear a helmet. My mom always told me to wear a helmet. I did not wear one when I went snowboarding, and I got a concussion when I was in college. Should have done that. Should have worn a helmet. Have your kids wear helmets. You should wear a helmet when you're riding bikes. When you're riding motorcycles, wear a helmet. Try to prevent yourself from getting any head trauma, and that will significantly lower the chances of you having dementia. Next slide. So, in summary, Alzheimer's is a super common disease with a huge disease burden. We don't have any treatments that halt or reverse the course. There's none. We don't know what causes Alzheimer's. It's still debated. There's hypotheses, and we see things on slides. However, when those things have been targeted by drugs, there has not been any significant difference in the prevention or reduction of Alzheimer's. So we don't totally know. The great news is that we have the power to reduce or prevent Alzheimer's in our own lives. It's really our own decision. If you look back at a lot of these talks, it all comes down to diet and exercise and healthy living. Everything, diabetes, we've talked about obesity, we've talked about high blood pressure, we've talked about kidney disease, we've talked about all those things. And the common underlying theme of treatment is exercise, nutrition, living healthy. So if there's anything you took from this talk, it would be that last star, that you guys have the power, I have the power to prevent or reduce Alzheimer's incidence in my own life and in my children's lives It's really up to us. So with that, 1959, 20 minutes on the dot.
That was impressive. That was impressive. And as you said, that's a very high level. I mean, people spend their entire lives on just this topic. I've seen a lot of people and a lot of research on all of the things that you talked about and the mystery around Alzheimer's and what types of things can we do. So I feel a little bit educated about this, but I wanted to ask you,
Yeah, go for it.
in general, your opinion on how to what do we do when we find out that maybe a loved one has a diagnosis of something? You know, we tend to dive into the internet and go find information. Do you have any thoughts about just like places that we should go and maybe some that you should avoid? Because, you know, you could easily find some incorrect information as well. What's your advice to people to educating themselves about not necessarily Alzheimer's, but maybe any disease?
Yeah, I love when patients go on the internet. I do. I mean, the internet's a great resource. I go on the internet. Like, I go read stuff on the internet. With Alzheimer's, honestly, if you Google Alzheimer's, like the top 4 things that are going to pop up are going to be the things that you want to click on. If you Google Alzheimer's, you're going to get like an alzheimers.org. You're going to get like a CDC website. You're going to get some Alzheimer's Foundation website. All that stuff's going to be really good. The one thing that you said, which I didn't talk about in the talk, but I was hoping that somebody would ask, was that a lot of times the person that notices that there's something going on is not the patient. So when you think about heart disease and stuff like that, people come in and tell you my chest is hurting, or people come in and say, I've been like sweating a lot, or I have this cough, or I have this symptom. Alzheimer's is very insidious and hard. It takes a lot of the insight away also. So a lot of times, until something gets really severe, like no one says anything about it. I've had patients that I talked to for like 3-4 years who all of a sudden they say something a little bit off, and I go to screen them for Alzheimer's, and it's positive. And it's probably been positive for at least a year or two, but they've been able to go unnoticed by the medical system because a lot of the way we communicate with people, the way we go about our day, we never actually get to like that top brain function level. It's always kind of like below the surface. And so you can have a full conversation with somebody and they could not know what year it is. It happens all the time. And so what I would say is, if you have a concern that a loved one is suffering from memory loss, then one, it's super helpful if you go to the appointment with that loved one, because a lot of times it's difficult to be like, hey, mom, or hey, dad, you need to go tell your doctor about your memory. It's like, well, one, are they going to remember to tell you? 2, they probably don't want to. So going with them, setting the time to go with them, not only is helpful to the patient, but also helpful to the provider. And so that's a great way where you can start the screening process and you can kind of start the conversation rather than, unfortunately, having to play catch up, which is never a good thing to do.
Well, you had that slide that said that that symptoms there would be, I'm just flipping through this
30 to 50 years before.
Yeah, that's the one I think that's the most concerning, because but if it was detectable 30 to 50 years before symptoms, that would be something.
Well, there are some emerging things where they can actually see some of that. And they actually think one of the primary changes that happen in the brain is glucose metabolism. And so one of the thoughts is that you're not metabolizing glucose as efficiently. And you can actually use these radioactive tracers to kind of see how the body or how the brain is processing it. Super expensive to do. We can't do it for everybody. It's more of like a research thing. However, in real life, how that manifests is actually a lot of people with Alzheimer's and stuff like that will develop this really intense sweet tooth. And one of the hypotheses is that their brain is actually crying out for sugar because it's not processing it as effectively. So maybe down the road, we have something like we can test people's blood sugars and stuff like that for diabetes. Maybe down the road, something where we can view glucose metabolism in the brain might be an early marker, that's one of the things that might start 30 to 50 years before. So yeah, that'd be great.
Another reason to limit sugar intake in your diet, right?
There you go. Yeah, I know.
We have a question from Melissa. Could you please explain the difference between Alzheimer's and dementia?
Yeah, totally. So dementia is the umbrella. That's like, if you go back to my second slide, I think it's my second slide. Dementia is right there. So dementia is the overarching thing. It's the progressive memory loss, basically. Now there's 4 types of dementia, and Alzheimer's is one of them. And we talked about that one because it's the most common cause. It's the one that almost everybody has. Probably the second most common is probably vascular dementia, which is basically somebody had a stroke and then now they have memory problems. You could consider that vascular dementia. The other 2 are a little bit out there, but Alzheimer's is the most common. So again, dementia is this overarching umbrella, and underneath dementia are these 4 types: Alzheimer's, Lewy body, vascular, and frontotemporal.
Thank you for the question, Melissa. We appreciate that a lot. I feel like you opened a door for me to bring this up. You mentioned Dr. Dower's presentation.
Yeah.
Dr. Racine as well, who spent a lot of time and is board certified in endocrinology and really talks a lot about diet.
Yeah.
But in her presentation, Dr. Dower presented the book How Not to Die, and it's talking about diet and the impact diet has on your health. And so I bought the book and I'm so proud of it. And I always, when she was here, I was waving this in front of her and saying, see, I was paying attention, because that really got my attention about diet. And my diet is terrible. When you put the list of things up there not to eat, that looks like what I eat. So I'm really working on that. But this book is fantastic. And there's a chapter in here on brain disease and quite a bit about Alzheimer's and dementia specifically, but Alzheimer's. But I mean, you probably could record a speech about diet and just play it again and again to every single patient you talk to. I would think the vast majority, right?
Yeah. I mean, I gave a talk about diet and exercise. Actually, I think it was the first Evergreen talk.
Maybe you inspired me, and I don't know. I'm thinking it was Dr. Dow.
Well, I did go back. So my talk on diet and exercise was a year ago, and Dr. Racine's was a few months ago. And I watched a bunch of them last night. And actually the common theme was you frequently bringing up, like, this is my diet. And every time you're like, oh my gosh. However, like, you're in the same boat as the rest of us. Like, we all have things that we can clean up on our diet. I think that book is a great resource. Michael Greger, he actually came to UCC and gave a talk a while ago. He's a big Blue Zones guy.
Right.
So he promotes a lot of the vegetarian and vegan lifestyle, which I think is very good for a lot of people. And in Douglas County, a lot of times when I bring that up, like, people will laugh at me, especially my ranchers. And so it's a great book, and I think everyone would benefit from reading it. Even if you don't want to dive in vegetarian, vegan, which I think is fine if you don't want to, there's still a ton of lessons that you can learn in that book, or going and listening to Dr. Dower's or Dr. Racine's talk, where it's like, even if you asked either one of them, would you be happy if somebody took like 5% of what you said and applied it? They would be like, yes, absolutely.
Right.
Yeah.
Yes.
That's the place to start.
Yeah. Well, thank you for reminding me that not only had I forgotten that this was your topic a year ago, but also that in every single one of these, I mentioned my terrible diet. I would like you to know. And if my doctor is watching right now, who is at Evergreen, I have taken changes since the last time we were together. Dr. Bonds, I'm working on that real hard.
He knows a lot about it too. He's a great, Dr. Bonds is really smart. He's a good one.
Well, anything else you really want to touch on or maybe reiterate as we close?
No, I think, I mean, a lot of it comes down to diet and exercise and some of those other things. I didn't talk a lot about the family dynamics and kind of what goes into the long-term treatment of Alzheimer's. And I think that that's best served in a talk on its own, because that's just such a huge topic, and it really is it deserves a lot of time. It takes a lot of time to have that conversation in an office visit with my patients. And so I think at a later date, we'll probably talk more about kind of that longer term care, or maybe the caregiver side of Alzheimer's or in dementia in this case. And I'd love to see somebody talk about that later, because that could be a really good resource for family members also. This is kind of like an overview of like, what is it? Who gets it? How do we treat it? But really the big burden of it is like, what do we do what do I do with mom and dad? And that's a separate conversation.
Yeah.
So,
okay. Michael Graham, PA at Evergreen Family Medicine, our Evergreen talk for today. And you can see more about Michael. You can research him, actually. His bio is there at evergreenfamilymedicine.com.
Still believe in the Blazers too. Yeah. Good year this year. Yeah.
Yeah, they're off to a great start. Evergreenfamilymedicine.com for more information. And then always join us, make plans to be here on the second Thursday of the month for Evergreen Talks, as Evergreen providers provide information that we think is of interest to the general public here in Douglas County. Feel free to share this with loved ones to get an overview of Alzheimer's and dementia, and then take action like Michael said. And we will talk to you again here in 1 month. It's good to see you, Michael. Appreciate all the information.
Yeah, definitely. I'll see you around.
Okay.
All right.
That's another Evergreen Talks. Goodbye.
Bye.